Hi everyone, thanks for listening to my presentations. Today I'll be talking about a very familiar topic but very confusing called subclinical hypothyroidism. Here, this presentation will be a bit funny because there will be debate, and unfortunately I'll be the only person for both sides. Okay? If you haven't listened to part 1, 2, 3, and 4, please kindly do. Sit back and let's go. Subclinical hypothyroidism. Just as the name depicts, it is subclinical. But we're going to find increased thyroid stimulating hormone with normal T4. There will be vague symptoms. So the symptoms will not be specific. Just as I've said the second point or third point here, there is non-specific symptoms. No clinical diagnosis per se. The diagnosis is limited to the laboratory results only, and this will have about 4 to 15% prevalence. Pretty confusing, right? Still on subclinical hypothyroidism definition, this is higher in females, and it increases with increase in age. It is lower in blacks. It is more in regions with iodine insufficiency, particularly in Europe. I want you to pick that rightly. Subclinical hypothyroidism is more in regions with iodine insufficiency. 4% in iodine deficient places and 24% in iodine sufficient places. You can see that it is more in iodine sufficient places. What are the possible causes? It is likely as a result of thyroid stimulating hormone receptor gene mutations, or as a result of autoimmune thyroiditis. Could be as a result of subacute thyroiditis or postpartum thyroiditis. Might be caused by painless thyroiditis or partial thyroidectomy. The use of radioactive iodine therapy could be the cause, while radiation to the neck or head region or head and neck region could be the culprit. Still on causes, iodine-containing medications like amiodarone could be responsible. And it could be as a result of those medications that have the capability of impairing thyroid function. For example, lithium and mood stabilization, cytokines, ethionamides like propylthiouracil, metimazole, or sulfonamides or sulfonylureas in diabetes mellitus. Still on causes, could be as a result of inadequate replacement in the phase of hypothyroidism. So the person had been diagnosed with classical hypothyroidism, either central or primary or secondary, now on levothyroxine, but not enough dosage. So the individual could become subclinical hypothyroidic. Increasing T4 clearance. For example, someone is diagnosed with hypothyroidism, is on treatment with T4 or you call it levothyroxine, but at the same time, person is taking some liver enzyme inducing medications like phenobarbital, phenytoin, and the rest. Then the rate of clearance of T4 will be very rapid. With that, the effect of T4 will become reduced, and then not fully out of hypothyroidism, but staying in the middle, subclinical hypothyroidism. Could be as a result of malabsorption of T4 in someone taking levothyroxine for the treatment of hypothyroidism. If you check my channel, I have made a separate presentation on relationship between soya milk and T4 absorption in the gastrointestinal tract, because Concomitant ingestion of soya bean and T4 per oral will lead to inhibition or impairment of absorption of T4. So if that is the case, then the individual on treatment could be treated to subclinical hypothyroidism. It might be as a result of thyroid infiltration like amyloidosis or hemochromatosis. It might be as a result of acquired immune deficiency syndrome in HIV positive patients or as a result of environmental toxins. What are the clinical features? Well, the main clinical features we're going to pick will be centered around the laboratory value, and that is thyroid stimulating hormone will be less than 10 milli international units per liter. You know, in hypothyroidism, we expect something 10 and above, right? Here, it's not pretty low like we find in hyperthyroidism, whether undetectable or just 0.1 or whatever, but it's high but not so high. So it's just a confusing situation and topic, right? Mostly it will be asymptomatic, except for the lab value that will be taken around and sent to our colleagues. This is what I pick in this patient. What am I going to do? This is subclinical. Some have symptoms, but the symptoms are not classical of that of hypothyroidism. No. Still on clinical features, there could be cognitive impairment, particularly when we are dealing with older people having subclinical hypothyroidism. It could come down with depression, decreased activities of daily living or instrumental activities of daily living. Maybe they had the capability to bathe themselves, dress themselves, make their phone calls, drive around, do their banking, or could become decreased or impaired right now. There is that possibility of fatigue and constipation. Remember, all the above presentations could be caused by any other medical condition or conditions. So the fact that someone is having fatigue, constipation, decreased activities of daily living or instrumental activities of daily living or depression doesn't mean it is hypothyroidism alone. Even vitamin B12 deficiency could cause that. Psychiatric disorder, depression could cause that. Dementia could lead to that. Anemia could lead to that. Hypoglycemia could cause that. So it's not specific. Diagnosis. When we are suspicious of thyroid-related problem, we'll do thyroid function test, right? Here, TSH will be high, but not high enough to the point we'll call it hypothyroidism fully, right? But T4, free T4 will be within normal range. We are going to repeat that thyroid function test after 3 months. Why that? Thyroid stimulating hormone can be transiently raised. That is just the meaning, transiently. Within a short period of time, it's raised and is back to normal. And that could happen in pregnant women, women undergoing infertility evaluation, women taking infertility treatment. We have to repeat thyroid stimulating hormone and T4 immediately in A to C above. And we will give our T4 for treatment if thyroid stimulating hormone is increasing. Okay, differential diagnosis. Since subclinical hypothyroidism is neither here nor there, then let's think about other possible conditions that could mimic that. Okay, recovery from non-thyroid illness can transiently raise thyroid stimulating hormone. That is one differential here. It might be that there is illness in this person that is not even related to thyroid gland, but TSH is raised within that time the individual is suffering, having that particular ailment. It might be hypothyroidism following hyperthyroid phase of subacute painless or postpartum thyroiditis. and that would be transient also. Just the English word, transient. Short time will come and go. It might be assay variability, okay? Might be the factor like a lab error. So it depends on what you are given, right? You take the sample and the lab people will do their good job and send the results to you and you make the determination, right? It depends on what has happened in the lab. Erythrophilic antibodies can also alter the level of TSH. Still on possible differential diagnosis, if this individual is having rheumatoid arthritis with rheumatoid factors, there can be interference with thyroid stimulating hormone because rheumatoid factors can act as heterophile antibodies. How about that? So if someone is diagnosed with rheumatoid arthritis already, and you know the value of rheumatoid factors in that individual, and now the TSH is high, be careful. It might be that rheumatoid factors are just acting as heterophile antibodies. It might be as a result of untreated adrenal insufficiency, okay, or autoantibodies to thyroid stimulating hormone. It might be thyroid stimulating hormone producing pituitary adenomas. So when you do your CT scan, you get that. Still on possible differential diagnosis, because subclinical hypothyroidism is neither nor there. Could be as a result of resistance to thyroid hormone. Might be secondary to central hypothyroidism with mildly increasing TSH of 10 milli-international unit per liter and low or normal free T4. The next differential diagnosis is pretty worrisome. This might be as a result of morbid obesity. Why that? Leptin in them will mediate high thyroid stimulating hormone production. But note this, the thyroid stimulating hormone that is high in morbid obesity will drop when individual embarks on activities or diet or lifestyle modifications that will lead to weight loss. So once the weight is dropped, the TSH will drop. So you don't need treatment. Or when the individual undergoes bariatric surgery, then TSH will be normal. Okay, history. We need to take thorough and appropriate history here, particularly the history of medication. Remember, you can rewind. Amiodarone, I've just stated in the last few minutes, will have iodine. That could play a role here. And some medications could actually interfere with production of thyroid hormones like lithium, ethionamines, and so on. It may be secondary to Hashimoto's thyroiditis. Then, here is the funny part of this presentation today. I'm going to have debate by myself for or against treatment of subclinical hypothyroidism. For will have red color, against treatment will have green. Let's go. All right. If we refuse to treat a patient with subclinical hypothyroidism, we are likely going to be dealing with persistent subclinical state if it is post-surgery. And with subclinical state that is not really affecting the individual so much, to those who believe that we should not treat, that is for them. There is likelihood of spontaneous recovery, even if you refuse to treat. That is for those who argue against treatment. So they won, right? Two ways. Okay, let's go on. If we refuse to treat or we fail to treat subclinical hypothyroidism, there's a likelihood of progression to hypothyroidism fully. I meant overt hypothyroidism. And that will occur in about 30 to 40% of affected individuals. That is for treatment, right? So that is supporting those who want to treat. And I've now colored that red. If we refuse to treat, there is that likelihood of increasing cardiovascular diseases. That is supporting those who want to treat, right? Because someone with subclinical hypothyroidism not treated can have increased coronary artery disease, can have heart failure, stroke, and of course, hyperlipidemia. Why not treating them? That's second point they've won, right, for treatment. If we refuse to treat or we fail to treat, there is likelihood of decreased fertility in women with oligo or complete amenorrhea. For that reason, you have to treat, right? They won again for treatment. There is that likelihood of non-alcoholic fatty liver disease. That would be an argument for treatment, okay? And lastly, it is possible that neuropsychiatric symptoms will emanate, and then psychiatrists will be involved, there'll be problems, psychotherapy, all sorts of medication, dealing with the side effects, and so on and so forth. For that reason, you want to treat, right? Okay, let's now go and find out about the result. Okay, if we tabulate for and against, we have 7 points considered. Those who don't want to treat, they won in 2 out of 7, and that is about 29%. Those who will treat, they've won in 7 out of 7. As far as my presentation is concerned, they've won in 5 out of 7. I mean, those who would like to treat, they have 71%. If you want to put it by ratio, that is ratio 3 to 7 against to 4, respectively. So the debate is in favor of those who would treat subclinical hypothyroidism. And that is my own conclusion. Debate by one person, won and lost by the same person, okay? But my own conclusion here is I would treat subclinical hypothyroidism, but I will likely discuss with endocrinologists in my jurisdiction and discuss with pharmacists as well. In conclusion, if TSH is greater than 10 milli-international units per liter, please, no debate. Then treat. Treat with levothyroxine, or you call it T4. Why that? To prevent progression into overt hypothyroidism. Okay? If the value is between 4.5 and 10 mU per liter, then pause, discuss with your team. But if it is tricky, if you have a value of TSH between 7.0 and 9.9 mU per liter, you can treat if you are dealing with young people, particularly children. Why that? Hypothyroidism is a very serious problem in children. It affects the brain development and, of course, somatic development. Also useful in the normal functioning of all organs in all systems of the body. So, if you want to prevent future learning disability in that child, or mental retardation, or failure to thrive, please treat that young man or young woman with subclinical hypothyroidism right now. You can also treat in anyone under age 65. So, consider the age and consider the TSH level. Even if you have no symptoms here, you are making diagnosis of subclinical hypothyroidism, I got that, but how about the age of the patient? And what is the value of TSH? Those two should be considered very seriously. You can use the lowest dose in case you are not comfortable to treat subclinical hypothyroidism, but you are dealing with a younger individual. You can go for low dosage of levothyroxine. And of course, you monitor everything, the thyroid function test properly to prevent thyrotoxicosis. And with that, I've come to the end of this presentation. The next presentation will be all about mesodermal coma. I know you'll be interested to get that quickly. And I promise that will be published in the next few days. And that will form part 6 or 7 of this series on hypothyroidism. Thanks for listening. Please remember to share and subscribe to my channel so that you can get all my publications immediately they are released. I appreciate it.